A battlefield doctor wasn't always trying to save a wounded soldier. Sometimes he was racing against an enemy no one could see. The musket ball or sword had already done its damage. Blood soaked the uniform. Bone might have shattered beneath torn flesh. Yet the injury itself was often only the beginning. The true danger was what entered the wound afterward. Long before scientists understood bacteria, surgeons noticed a terrifying pattern. A soldier could survive the chaos of combat, endure the agony of surgery, and even appear to recover. Then, days later, everything changed. His skin became hot. His pulse quickened. The wound, once merely painful, began to swell until the surrounding flesh stretched tight. Thick, foul-smelling fluid seeped from the opening. The healthy red color faded into shades of gray, green, or black. Fever consumed him, followed by confusion, exhaustion, and sometimes uncontrollable shivering. No one could explain exactly why it happened. Today we know these were classic signs of severe bacterial infection, often progressing to sepsis or gangrene. But for most of history, doctors had no knowledge of microorganisms. The germ theory of disease would not gain widespread acceptance until the 19th century through the work of scientists such as Louis Pasteur and later Joseph Lister, whose antiseptic methods revolutionized surgery. Before then, physicians relied on observation rather than understanding. They gave this invisible killer many names: hospital gangrene, putrefaction, blood poisoning. Each described the horrifying transformation they witnessed, even if the cause remained hidden. Military hospitals became places where the smell itself warned of danger. Contemporary accounts from conflicts such as the Napoleonic Wars and the American Civil War describe wards heavy with the odor of decaying tissue, dirty bandages, sweat, smoke, and human waste. Surgeons recognized the scent immediately. It often meant death was approaching. Ironically, many battlefield wounds were not initially contaminated by the weapon alone. Bullets carried fragments of clothing deep into muscle. Dirt, splinters of wood, pieces of leather equipment, and even bits of shattered bone became trapped inside the injury. Every foreign object created another opportunity for infection to flourish. Modern medical research confirms that contaminated wounds containing dead tissue and embedded debris provide an ideal environment for bacterial growth. Without antibiotics, the body's immune system was often overwhelmed before it could control the infection. The tragedy was that battlefield doctors could see the pattern repeating again and again, yet they possessed almost none of the tools that modern medicine takes for granted. There were no antibiotics, no sterile operating rooms, no laboratory tests to identify the infection. Only experience and increasingly desperate methods. Some treatments seemed almost cruel. Others accidentally helped more than their inventors ever realized. But there was one procedure that terrified every wounded soldier more than the injury itself. The first battle was over. The second battle had just begun. Inside a crowded field hospital, surgeons knew that every passing hour gave infection another chance to spread. A wound that looked survivable in the morning could become deadly by nightfall. There was only one problem. They had no medicine capable of killing the invisible organisms causing the disease. So instead, they tried to destroy the environment where infection thrived. The first step was often brutally simple. Open the wound wider. To a frightened soldier, this made little sense. The injury already hurt beyond words. Yet surgeons believed that closed wounds trapped bad matter inside the body. Although their explanation was based on observation rather than germ theory, opening the wound frequently allowed blood, pus, dead tissue, and contaminated debris to drain away. Modern trauma surgery still relies on a similar principle called surgical debridement, removing dead or contaminated tissue so healthy tissue has a chance to heal. The instruments were primitive, but effective in skilled hands. Scalpels sliced through swollen flesh, Long forceps searched for fragments of cloth, shattered bone, or splinters driven deep by musket balls. Surgeons scraped away tissue that had already begun to die. Every cut was made without knowing whether it would save the patient or simply leave him too weak to survive. The pain was extraordinary. Before the widespread use of ether and chloroform in the mid-1800s, many soldiers remained fully conscious during these procedures. Some were given alcohol or opium to dull the agony, but neither could eliminate it completely. Witnesses described men gripping wooden tables until their knuckles turned white, while assistants held their shoulders and legs to prevent sudden movement. Then came the washing. Clean water was often scarce on campaign, so wounds might be rinsed with whatever was available. Wine, vinegar, diluted spirits, or salt water were common choices. Surgeons believed these liquids could cleanse corruption from the flesh. They did not know they were sometimes reducing bacterial contamination by accident. Historical records also described the use of honey in certain military and civilian settings. Though not universal, honey had been valued since ancient Egypt and Greece, because physicians noticed that some wounds treated with it healed surprisingly well. Modern research has shown that medical-grade honey naturally inhibits many bacteria through its acidity, high sugar concentration, and production of small amounts of hydrogen peroxide. What appeared to be folk medicine occasionally had genuine scientific value. Not every treatment was so fortunate. Some surgeons poured boiling oil or applied red-hot irons directly to infected wounds, believing intense heat would stop decay or control bleeding. The smell of scorched flesh filled the tent. Smoke mixed with the metallic scent of blood. The patient often screamed until exhaustion replaced strength. French military surgeon Ambroise Paré, writing in the 16th century, challenged one of these practices after running out of boiling oil during a campaign. Forced to improvise, he used a gentler dressing made from egg yolk, rose oil, and turpentine. To his surprise, the soldiers treated with the mixture often recovered better than those who had been burned with hot oil. His observations became one of the earliest examples of questioning established surgical tradition through careful comparison. Even after cleaning, washing, and cutting away damaged tissue, the danger remained. Hours later, the wound could swell again. Fresh pus might appear. The skin around the injury could darken as healthy cells died from lack of blood supply and overwhelming infection. Flies settled on damp bandages almost as soon as they were applied. In crowded hospitals, where hundreds of wounded men lay only feet apart, the conditions favored disease at every turn. Experienced surgeons watched these signs with growing dread because they knew what often came next. If the infection continued climbing through muscle toward the nearest joint, there was only one treatment left, and nearly every soldier feared it more than death itself. For many wounded soldiers, the most terrifying words in the hospital were never spoken on the battlefield. "Hold him down." By the time a surgeon reached that conclusion, the infection had usually won every other fight. The wound had become swollen and hard. The skin no longer looked alive. Dark streaks sometimes crept up the arm or leg as infection spread through damaged tissue. The smell changed, too. Veteran surgeons recognized it immediately, a sickly, sweet odor that often signaled gangrene. Once that smell filled the room, everyone understood what might come next. The real problem hadn't even begun. Without antibiotics, there was no reliable way to stop a rapidly spreading infection inside a limb. If dead tissue remained attached to the body, bacteria continued multiplying. As toxins entered the bloodstream, fever climbed higher. The soldier became restless, then confused. His breathing grew shallow. Many slipped into what modern medicine recognizes as septic shock, a condition that is still life-threatening today, even with advanced intensive care. So surgeons made an impossible calculation. Lose the limb or lose the life. Amputation was never considered a cure for the original injury alone. In many cases, it became an emergency attempt to remove infected tissue before the disease spread beyond control. Historical analyses of military medical records from conflicts, such as the American Civil War, show that patients who underwent early amputation after devastating limb injuries often had a better chance of survival than those whose infected limbs were left untreated. It was a brutal decision, but experience repeatedly pointed surgeons toward the same conclusion. The operating table was rarely more than a sturdy wooden door laid across barrels or trestles. Blood from previous patients stained the surface, despite hurried attempts to wipe it clean. Instruments were sharpened constantly, not because surgery was gentle, but because speed mattered. Every extra minute meant more blood loss, more pain, and greater exhaustion. After the introduction of ether in 1846 and chloroform soon afterward, many, but not all, patients could be anesthetized. On chaotic battlefields, supplies ran short, conditions were unpredictable, and some operations still took place with little more than alcohol or opium for relief. Earlier wars offered no anesthesia at all. A skilled military surgeon worked with astonishing speed. The knife cut through skin and muscle in smooth, practiced motions. Large blood vessels were tied off with silk ligatures to reduce bleeding. Then came the bone saw. Its coarse teeth produced a harsh, rhythmic sound, unlike anything else in the hospital. Assistants held the limb steady, while the blade bit through bone. Within moments, the damaged arm or leg was separated from the body. The remaining muscles were trimmed, folded over the exposed bone, and stitched to create a stump that, if infection could be controlled, might eventually heal. The entire operation sometimes lasted less than 10 minutes. Not because surgeons lacked compassion, because they knew lingering over the procedure could kill the patient. Outside some field hospitals, piles of amputated limbs grew throughout the day. Visitors described heaps of arms and legs stacked beside tents, waiting to be buried. The sight became one of the defining images of 19th century warfare, not because surgeons were careless, but because thousands of catastrophic injuries arrived faster than any medical service could handle. Yet survival was never guaranteed. Removing the limb eliminated the obvious source of infection, but bacteria could already be circulating through the body. Some patients awakened from surgery with cautious optimism, only to develop raging fever 2 days later. Others, against every expectation, slowly regained strength. No surgeon could predict which outcome awaited the next patient. And for those who survived the operation, an even longer struggle was just beginning inside the crowded military hospitals, where danger lurked in places no one suspected. Surviving the operation did not mean surviving the war. For thousands of soldiers, the real test began after the surgeon put down his knife. The hospital ward was supposed to be a place of healing. Instead, it often became the most dangerous place they had ever entered. Rows of narrow cots stretched across churches, barns, schools, warehouses, and canvas tents converted into makeshift hospitals. Every bed held another wounded man. Some whispered in pain. Others cried out with fever. The sound of coughing, groaning, and hurried footsteps rarely stopped, even at night. The air itself felt heavy. The smell was unforgettable, a mixture of sweat, damp wool uniforms, blood-soaked bandages, smoke from oil lamps, human waste, and infected wounds. Contemporary nurses and surgeons frequently described opening windows whenever possible, believing fresh air could drive away disease. Although they misunderstood the exact cause, better ventilation sometimes reduced the spread of airborne illnesses and improved overall conditions. But fresh air could not solve the greatest problem. Everything touched everything else. A surgeon might move directly from one patient to the next without changing his apron, which had become stiff with dried blood after hours of operating. The same instruments were often rinsed in cold water before being used again, Bandages, when supplies became scarce, were sometimes washed and reused. No one realized these everyday practices could carry microscopic bacteria from one wounded soldier to another. The result was devastating. A man whose operation had gone perfectly could suddenly develop a new infection days later. His surgical wound became warm and swollen. Thick yellow or green pus collected beneath the stitches. The edges of the incision pulled apart as damaged tissue died. If hospital gangrene took hold, healthy flesh could seem to disappear almost overnight, leaving dark, decaying tissue behind. Medical reports from the American Civil War and the Crimean War describe hospital gangrene as one of the most feared complications facing military surgeons. Once it spread through a ward, it could infect patient after patient, despite every effort to contain it. Doctors tried almost everything. They changed dressings frequently. They irrigated wounds with vinegar or diluted chlorine solutions. Some applied nitric acid directly to infected tissue, hoping the powerful chemical would destroy the diseased flesh before it spread further. The treatment was agonizing, but in certain cases, it slowed the progression of gangrene by killing contaminated surface tissue. Modern medicine recognizes these methods as crude precursors to chemical antisepsis, though they were dangerous and inconsistent. Then there was an observation that puzzled doctors for centuries. Occasionally, wounds filled with tiny white maggots appeared cleaner than expected. Most people recoiled at the sight. Yet some military surgeons noticed that the larvae seemed to consume dead flesh while leaving living tissue relatively untouched. Patients whose wounds contained these insects sometimes recovered when others did not. Because the idea was so unsettling, few physicians intentionally relied on it at the time. Modern medicine has since confirmed that carefully sterilized medical maggots can remove dead tissue and reduce certain bacterial infections. What horrified 19th century surgeons would eventually become a scientifically accepted treatment for selected chronic wounds. Recovery was painfully slow. Even soldiers who escaped infection faced weeks or months of healing. Every dressing change reopened pain that had barely faded. Muscles weakened from lying in bed. Amputees learned to balance again using crude wooden crutches. Many carried lifelong scars, not only on their bodies, but in their memories. Still, experienced doctors began noticing something remarkable. Some hospitals consistently achieved better survival rates than others. The difference wasn't luck, it wasn't stronger soldiers, and it wasn't better surgeons alone. A quiet revolution was beginning. Someone would soon prove that the deadliest enemy on the battlefield had been hiding on the surgeon's own hands all along. The greatest breakthrough in battlefield medicine did not begin with a new drug. It began with a simple question. Why did some patients survive while others, with nearly identical wounds, died from infection? For centuries, surgeons believed foul air, bad odors, or the patient's own constitution explained these deaths. But during the second half of the 19th century, that belief began to collapse. French chemist Louis Pasteur demonstrated that microscopic organisms were responsible for processes like fermentation and decay. His work suggested something revolutionary. If tiny living organisms could spoil food, perhaps they could also infect wounds. One surgeon paid close attention. Joseph Lister, working in Glasgow during the 1860s, applied Pasteur's ideas to surgery. If invisible germs caused infection, then preventing them from entering wounds might save lives. His solution was remarkably practical. Lister began cleaning wounds, instruments, dressings, and even surgeons' hands with carbolic acid, also known as phenol. He sprayed the operating area with antiseptic mist and insisted on cleaner surgical practices. The acid irritated skin and lungs, and later generations replaced many of his methods with safer techniques, but the results were impossible to ignore. Patients who once faced almost certain infection after major operations began surviving in far greater numbers. The change was gradual rather than immediate. Many surgeons resisted Lister's ideas at first, convinced that decades of tradition could not be wrong. Yet as hospitals adopted antiseptic and later aseptic techniques, post-operative infections declined dramatically. Clean instruments, sterilized dressings, hand washing, and carefully prepared operating rooms became the new standard. Battlefield medicine was beginning to change before antibiotics had even appeared. During later conflicts, military doctors increasingly emphasized rapid wound cleaning, removal of contaminated tissue, sterile bandages, and prompt surgery. These measures could not eliminate infection entirely, but they gave wounded soldiers something earlier generations rarely had: a realistic chance to heal. Then came the discovery that transformed medicine forever. In 1928, Alexander Fleming noticed that a mold growing on one of his laboratory culture plates had killed the surrounding bacteria. The substance produced by that mold became known as penicillin. Years later, researchers, including Howard Florey, Ernst Boris Chain, and their colleagues, developed methods to produce it in quantities large enough for medical use. Its impact became unmistakable during the Second World War. Infections that had condemned countless soldiers throughout history could now often be treated successfully. Wounds that once required desperate amputations sometimes healed with antibiotics and modern surgical care. Diseases that had haunted every military hospital for centuries became far less deadly. Even today, however, trauma surgeons follow principles that would feel familiar to many battlefield doctors of the past. Dead tissue must still be removed. Contaminated wounds must still be cleaned thoroughly. Severe infections sometimes still require repeated surgery. The difference is that modern medicine now fights alongside antibiotics, advanced anesthesia, sterile operating rooms, blood transfusions, intensive care units, and sophisticated imaging. Tools those early surgeons could scarcely have imagined. Looking back, it is easy to judge the crude methods of the past: the bone saw, the cautery iron, the vinegar-soaked bandages, the agonizing amputations. But those physicians were working against an enemy they could not even see. With limited knowledge and almost no effective medicines, they relied on careful observation, experience, and courage to give their patients any chance at all. Some of their treatments failed. Some accidentally anticipated modern science, and every lesson, earned through unimaginable suffering, helped shape the medicine we depend on today. The next time a deep cut is cleaned with sterile saline, closed in a spotless operating room, and protected by antibiotics, it's worth remembering how extraordinary that routine care truly is. For countless soldiers across history, those simple advantages would have meant the difference between life and death. If stories like this remind you how extraordinary modern medicine really is, consider subscribing so you won't miss the next forgotten chapter of history. And if one moment in this story surprised you the most, leave a comment below. Your curiosity helps keep these overlooked chapters of history alive. Until next time, thank you for watching.